Okay, Purva, shall we start?
Yes, sir, we can start.
Okay, thank you, Purva. So, good evening to all of you. As usual, I'll start with the short case first. Can you see my slide?
Yes, sir.
Yeah. This is a story of a 68-year-old female. She used to have episodes of left hemicranial and facial pain for the last 20 years. The episodes used to last for 1 to 2 hours without any photophobia, but associated with nausea and occasionally vomiting. The headache used to occur once in 1 to 2 weeks, sometimes 1 to 3 weeks. On most occasions, this was associated with facial deviation to the right. And the facial deviation used to subside when the headache subsides also. Only the lower part of the face used to deviate, no problem in eye closure at that time. On examination, indirectly, patient was perfectly normal, no neurological deficit. At the time of headache, there was facial deviation to the right without any weakness of the upper part of the face. So this is the picture of the patient at the time of headache. You can see the right lower face was deviated to the right. There is no problem in the eye closure. That is normal. So what do you think the patient is having? All the time the patient will not deviate. Sometimes the patient will deviate along with the headache. Sometimes headache occur without facial deviation also. Most of the time the face used to deviate.
So
Was
some
there
sort of an irritative lesion causing the headache as well as a transient hemimasticated spasm type of a phenomenon.
But the headache was typical of that of migraine only. Hemicranial with eye pain and used to vomit also along with that sometimes. And the headache is not like a lightning pain as you get a neurologic pain.
Any family history, sir?
No, family history is not there.
Can it be a type of epilepsy?
But the headache will last for about half an hour. Then it's not a twitching, it's persistent deviation and then disappears.
A type of hemiplegic migraine?
Yeah, this is some kind of a type of, apart from hemiplegic, you can call it a facial paretic migraine, no? Something like equivalent to hemiplegic migraine. So that is a thing which you can reasonably think of.
Is a facial palsy is confirmed, sir?
Yeah. There is a deviation to the right. This is a picture which I have shown you, no?
Is
Okay.
really a facial palsy or a functional type of facial palsy?
It was a deviation to the only at the time of headache, and it disappears along with the substance of the headache. It's used to vomit out.
Handle?
Pardon?
Handle.
Can be handled, but the only thing is that here it is only the facial pulse deviation.
The past pedacel or caracel-like lesion.
Okay, these are possibilities, but it's a classical migraine with a focal deficit. So what do you call something like
Migrainous facial pulse.
right. Something like a migrainous facial pulse. Okay. Now the story does not end. Please.
But the deviation is the same side of headache.
Right. Headache is on the left side. The facial deviation, your pulse is also on the same side. That is the usual thing. Monser asks a very pertinent question. Usually in migraine, the deficit also on the same side. Suppose you have got hemiplegic migraine, headache on the same side as the weakness. Suppose you've got blurring of vision along with the headache or hemianopia, it occurs on the same side as the deficit. Usually expect on the opposite side, no? In the case of structural pathology. Here is on the same. That's one important point differentiate migraine from a structural cause causing the headache and focal deficit. For example, AU malformation causing headache and focal deficit. The headache is on the one side and deficit on the opposite side. It is curiously, it is on the same side.
Also, it explains.
No, this question I asked sometime back in a headache specialist. He couldn't answer why it is occurring on the same side as the focal deficit. Paresthesia on the left side, same side, the headache is also occurring. But that is typical of migraine. If you get a history, that's quite typical of migraine. Okay. She was investigated with hemogram, MRI brain, and even CT angiogram to find any vascular lesion causing this facial elevation. All were normal. Now, she was put on anti-migrainous treatment, and she had no further episodes while on treatment. Whenever he used to, and attacks every time when she attempted to stop the medication. Sometimes get a headache and the facial elevation. Then when I ask him, she would have stopped the medication at that time. Okay, so it's some kind of a migraine phenomena. The story does not end there. For the last 3 years, patient complained of inability to open her left eye on awakening from the sleep, along with the left hemicranial and eye pain. At that time also there was facial elevation. Examination of the ocular movements were normal at this time, and there was no history of diplopia. Along with this, she was also noticed a facial elevation to the right, just like before. It's all occurring on the same side. Both the ptosis and the facial elevation used to subside along with the subsidence of headache. So it's a different, initially it was facial, now it is only ptosis. Something like a hardness, but pupil is normal at that time. Now this is at the time of the episode, video at the time of the episode. There's got a facial elevation on the right side, and she's unable to open her eye fully on the left side. This is the ptosis, and after 5 minutes, this ptosis not totally improved, much better than before. And the facial elevation also improved. What is the diagnosis now?
This you have shown previously.
Pardon?
This case you had shown previously. Early morning awakening.
No,
ptosis.
same patient, the evolution.
Early morning awakening ptosis.
No, that's a little different. That is awakening ptosis without any headache or anything. And after some time, even if you just put a hand on this thing, it will disappear. But here there is always the headache only. It also occurs along awakening, but with the headache. At the same time, there is facial elevation also. You saw the facial elevation.
There's a medial rectus is also along the ptosis.
Pardon?
Medial rectus is also weak. I think
No.
it's
Medial rectus is not weak.
bending.
No, the ocular movements are perfectly normal at this time.
Okay.
It will be
In fact,
basilar migraine.
maybe basilar migraine by ptosis. In fact, I skipped the last part of the video. Ocular movements are showing there is normal.
कुछ स्टार्टर मिलेगी सर मेन कोर्स
हाँ तो स्टार्टर क्या प्रॉन्स चिली
चिली प्रॉन्स एशियन चिली गार्लिक प्रॉन्स जो है
या चिली गार्लिक प्रॉन्स एक उसके बाद
Can
में
who is speaking? Can you please mute the mic, please?
ऑलरेडी ऑर्डर हो
हाँ ऑर्डर हो गया चिकन अपना स्टार्टर
Please.
मटन नंबर जो मेन कोर्स में बोले थे ओके
और स्टार्टर में ये अपने प्रॉन्स चिली प्रॉन्स
एशियन चिली वाली प्रॉन्स
Okay,
Hello, sir. Please speak.
प्रॉन्स पे ऑन साइड सॉस रहती है
Purva, can you mute that person's video audio? Purva, can you mute the person's audio who is speaking in between?
बटर प्लेन बटर या प्लेन
नहीं 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 मेरे को बटर नान एक
That is. Can you mute that video, please? Audio.
दो बटर
ग्रीन सलाद पनीर सलाद कॉम्प्लीमेंट्री देते हैं बाकी ग्रीन सलाद चालू रहेगी
नहीं 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 ओनियन सलाड ही दे
Purva, can you mute that person's audio?
नहीं लग रहा अच्छा वो ग्रीन सलाड वो क्या क्या आएगा उसमें
सर कुकिंग और कैरेट टोमेटो ऑनियन एंड बीटरूट
एक ग्रीन सलाड
ओके
प्लस कॉम्प्लीमेंट्री सलाड
ओके सर एंड पापड़ पापड़ मिल जाए
पापड़ पाहिजे पापड़ ठीक है
पूर्वा
एक
पूर्वा
पापड़ दो पापड़
तो सूप और स्टार्टर करना पड़ेगा
हाँ
उसके बाद
ठीक है
सूप आपका जल्दी लगेगा 5 to 8 मिनट बाकी स्टील वाली थोड़ा टाइम लगेगा 15 मिनट
चलेगा लाओ
ज्यादा
okay. Somebody was speaking
फर्स्ट
in
टाइम
between.
4:30 3 असंच आहे
आपण इथे आलो रूम सर्व्हिस मध्ये
3119
Sir, can we please restart the meeting because I don't think
Yeah.
he's being able to hear, sir.
Okay, okay. I think we'll start the meeting. Restart. Okay. Can you see my slide?
Yes,
Yeah.
sir. Please.
Yeah, right. Purva, there was some person speaking in between. I wanted to mute anyway. Now you stopped speaking now. Okay. Okay. I was talking about that he's sitting in the restaurant and giving orders to the person. Okay. Right. Okay. So that's the story of the patient. So what is the diagnosis in this patient?
Sir, it is some sort of a trigeminal autonomic cephalalgia like a paroxysmal hemicrania or a cluster, which can have ptosis or a Horner syndrome. Along with sometimes it may also have some facial deviation.
But have you seen this thing before? Facial deviation with the ptosis? Any kind of...
No, sir. We have seen isolated ptosis with redness in cluster headache, but not with,
Yeah, that is well known. That's a well-known thing. Even monitory migraine also can have ptosis, I have seen with congestion, but not
yes, sir.
facial.
Yes.
But this patient initially only facial elevation. Now, in fact, this case was published 5 years back before she developed this ptosis along with the headache. Now, that's an article published in Neurology India. That is a facial paralytic migraine, rare migraine. That is, this I have published a long time back. When this case was sent for publication, the referee asked me a very pertinent question before accepting for the publication. How can the author witness all such a paroxysmal episode every time the patient deviation? No, it's a very, very pertinent question.
Because she is wife.
You know what the reply I gave?
Because she is wife.
No, I replied that the author happens to stay with the patient and the article got published. The patient happened to be my wife. This is my wife's story.
Great, sir. Great, sir.
The same thing happened. They asked me, this is the thing. I gave the reply like that. Till that day, he was asking so many critical questions. Why can't you know about it, about all the episodes and all? Okay, so that's the story of that patient. So shall I go to the next case? Or any questions in this case?
Sir,
Ptosis also
the patient-
comes under this term.
Yeah, it is a pace. See, otherwise, no, in between, perfectly normal.
So what treatment did you give, sir? Amitriptyline alone, sir?
No, she's now on, she's on topiramate, propranolol, and amitriptyline.
The severity of the episodes, is it increasing or decreasing? Or the
No,
same?
once she's on medication, well controlled, no problem. When they try to stop them, as usual, every patient may also stops in between, she get the headache and get the ptosis. When she's taking it regularly, no attacks occurs. Funnily, it's always on the
Sir, in such episodes, the ptosis is due to a transient third nerve involvement or a transient Horner syndrome.
It was not like a Horner syndrome. They examined her. That was not correctable at that time. It is not a
That is
Horner
fine.
syndrome. Pupil was also normal.
The migraine usually it has to be according to the vascular territory of involvement.
That's correct. But sometimes it's very difficult to pin together all these phenomena.
Deficits are not
Right.
suspecting any vascular cause.
Right. Now, this as told before, no, the headache and deficit also occur in the same territory. It's also not fitting with the vasculature most of the time. We do not know what is causing it. Why it is on the same side also difficult test.
What is the reason for doses, sir?
No idea. No idea. I am seeing for the first time. I can postulate something, but there's no proof. Because initially, when the facial elevation occurred, I investigated fully, including a CT angiogram also I did.
Sir, points against basilar migraine, sir.
Yeah, it can call it as a tip 1 identify baseline. Nothing against. You can call it something nothing against.
So if it is a basal migraine, the process should be bilateral, sir.
No, that need not necessarily, can be unilateral also.
Sir,
Sir,
can it
that
go on to
tryptoma, does it work
hemiplegic
for
migraine?
basilar migraine, sir?
Pardon?
Tryptoma, does it work for basilar migraine? sir?
No,
Tryptoma.
that's just any drug. No, all these migraine drugs will work for any migraine.
In basilar migraine, usually triptans are contraindicated, sir, because of
No,
association.
not a triptan. This is talking about tryptophan, that is
Okay.
amitriptyline. Amitriptyline.
Okay.
Sir, can it go on to be a hemiplegic migraine or something like that, sir? Like,
No, that in if I this this is described for the first time. No, she has so far not developed any hemiparesis for the last 20 years. So very unlikely, that's the I can say.
So this doses and deviation occurs after onset of headache or before the onset of headache?
No, when she gets a headache, because she wakes up with a headache and he noticed doses in the morning. Which occurred earlier, I cannot say.
So you're going to send
Wait.
genetics to madam, sir?
No, I did not do the genetics in it.
Facial deviation is to which side? Which side?
Same,
side.
that is left side headache, facial deviation to the right side. Same side as facial palsy. You saw that the last film, the ptosis on the left side, facial deviation to the right. Okay. Shall I go to the next case? It's a long case.
Yes.
Okay. This is a story of a 78-year-old lady. She came with a complaint of decreased volume of her speech for the last 6 weeks, which progressed to total loss of voice over the next 3 weeks. There was no dysphagia, no nasal irritation. She went to the laryngologist, that's Dr. Jayamar is one of the famous laryngologists here. And he saw the patient details, and this is his observations. Both vocal cords show atrophy, movements normal bilaterally, phonatory gap spindle shape. This is the report from his note. Since he did not have any primary laryngological problem, she was referred to me. So I took the history once again. On retaking the history, she noticed difficulty in elevating her hands and for combing her hair for the last 4 months. The first complaint was actually this one. Whether the weakness was there earlier, we do not know. However, she was able to manipulate her fingers to wear her sari. Disturbances appeared to be normal. 2 months later, she noticed slowness in walking, difficulty in climbing stairs, and inability to lift her both legs to get into the bed. That's the story. She needed support for walking for the last 3 months. So going back to the history once again, the first complaint was 6 weeks with history of hoarseness, low volume of speech. Then she developed, going back to the history, she had 3 months, she was difficulty in elevating the hand, and 2 months noticed climbing up the stairs and unable to lift up both her legs into the bed. She needed support for walking for the last 3 weeks.
Sir, excuse me, sir. Sir, there's
Pardon?
confusion regarding the timeline, sir. First,
So, in
is
fact,
it low volume weakness or hoarseness of voice?
No, sorry. I spoke wrongly. The first thing was upper limb complaint. Then she had difficulty in getting onto the bed. Then 1 week later, she developed this low volume of speech. Low volume of speech is only for 6 weeks. Lower limb complaint is 2 months. Upper limb complaint is 4 months.
Okay.
Okay. Now, this is the video of the patient. Trailers are all normal. I'll show you the trailer. Neck flexors very weak. An examine upper part of the face is normal. There is lower facial weakness. And parrot was not moving at all. He could not make a voice like ah. There is no sound coming out. Tongue movements are, however, normal. This is a sound which is creating pa pa pa. I said la la la. There is no sound coming. That's the sound. Okay. Then we started examining further. Don't normally upper and lower limb. Disturbance and muscle power was normal. Then examine the fossil muscle. She had weakness of both deltoid. That is weak bilaterally. Biceps also weak little bit, not as weak as deltoid. It's also weak. But triceps was normal. Then the wrist section says finger extensions were all normal. Finger flexors were normal. Then coming to the lower limb, don't normal in the lower limb. Hip flexion was grossly weak. She could not lift it against gravity. That's the only thing which is possible. Knee extensions, however, normal. Dorsiflexion, plantar flexion normal. EHL was normal. Protection normal. Hip extension was slightly weak bilaterally. So hip flexion was weak, hip extension was weak. Reflexes were normal in the upper limb, so also normal in the lower limb. Angle jacks were normal. Plantar was indefinite. Sensations were all normal. Everything is normal. Vibrations also normal. Joint sense also normal in the upper and lower limb. She was asked to point with her hand. No, she was asked to get tremendous difficulty in getting up from bed. She has to be supported one person to get out from the bed. 2% to get up from the bed. Maybe tongue muscle is getting weak. And tremendous difficulty time down to the stairs. She's walks. This is the kind of walking. She's taking extra effort to push the legs forward. There's still probably if hip flexion is grossly weak. She could not stand on heel and toe, but whether it's real weakness, I am not very sure. But she could not stand on toes. And she could not get up from the sitting position. So on examination, she has aphonia, only whispering speech. Ocular movements normal, facial muscles, upper facial muscles normal, lower facial muscles and buccinator were weak. No palatal movement. Cannot say ah. Tongue normal. Neck muscles, neck flexors were weak. Motor, upper limb and trunk, weakness of both deltoid and biceps bilaterally. Triceps and other distal muscles normal. Could not get up from the bed. Lower limb, weakness of both hip flexors and hip extensors. Abductors, adductors were normal. Quadriceps normal. Distal muscles could not stand on heel and toes. Testing at the bedside, they appeared normal. Could not get up from the stool. DTR all normal. Sense system normal. Rhombus negative. Gait, tremendous difficulty to get up from bed and initiate walking. She drags both feet, probably because of the hip flexion weakness. So, where is your localization in this patient?
Any fasciculations?
No fasciculations. Good question. No fasciculations.
Strictly motor disease, which is an element type of an illness, which is rapidly progressing from the appendicular skeleton and involving the bulbar musculature very early, sir, in the course of a disease. Probable neuromuscular junction illness of considering her age, any paraneoplastic etiology causing a neuromuscular illness like musk myasthenia or Lambert-Eaton. Polyradiculopathy is a little unlikely considering only laryngeal palsy and absence of sensory. If there was sensory, we would also consider Miller-Fisher variant of polyradiculoneuropathy.
Okay. The point against a polyradiculopathy is that her maximum brunt of affection was the laryngeal muscle. At the
Yes,
same
sir.
days, even she could swallow without any problem.
So, but sir, isolated laryngeal involvements are sometimes reported in Miller-Fisher only. So that's why I was telling only.
Right. I have also seen a patient with Amman variant where they had involvement of the laryngeal muscles, but they are not
Yes.
common.
No, sir. Definitely, sir.
Maybe a primary
Neuromuscular junction.
Reflexes are all preserved. That's the point.
primary muscle disease.
Yeah, primary muscle is also possible.
Polymyositis sometimes.
Yeah. But do they preserve the laryngeal palsy? Usually dysphagia is the complaint they come to.
Anterior disease of atypical.
Which one?
Anterior console disease.
Yeah.
Anterior console disease.
That is one of the strong possibility you have to keep when the patient with the laryngeal involvement and weakness of the limb muscles without any sensory, with retained reflexes. The knee jerk slightly appeared slightly brisk also in this patient.
NXP2 myositis.
Pardon? NXP2 myositis. Okay. So
Any
possibility
issue of sleep abnormalities?
No sleep abnormality. The only thing is subacute. There was not much of a wastiness, a slight problem against anticonsal, but the predominant affection was the proximal muscle. So myopathy is one possible. Anticonsal is most likely possible in the laryngeal involvement. And reflexes were quite brisk, even though the muscles were weak in the lower limb. Okay, so these are the possibilities.
Any fasciculation, sir? History?
No, basically the history also. Okay, what test you need?
NCS and RNST.
Okay, very good. So went ahead with their NCS. The amplitude, the Peroni was slightly low, but you don't take it as very significant. Many of the persons which we do here, this comes as low. Is it a problem with the technique or do we do not know? Whether maybe technical. All other potentials are of normal size, normal amplitude. TA was normal, tibial normal. Then left median was normal. Sensory potentials were normal. And FA was also normal. The problem is her affection was in the hip flexes that we cannot do the contraction study. But the available parameters are all normal. So A polyradical neuropathy seems less likely because all of the nerves seems to be normal. FA latency is also normal. Now, what else you want to do?
RNS.
EMG. Yeah, RNS.
EMG and RNS.
Serum CPK.
Okay. We'll go one by one. So, it is an RNS that is negative. Okay. Then, did a CMAP after 10-second exercise to rule out Eaton-Lambert syndrome. But again, no increment in the amplitude. It was 11 and 12.2. So that's also, so myasthenic syndrome seemed less likely in this patient.
What was the exercise advice, sir?
Exercise?
Done.
You mean
Exercise.
the fatigability?
Yeah, for Eaton-Lambert, will sit.
That's the exercise test, no? The 10 minutes, the 10-second exercise. Initially do a CMAP amplitude as just like do motor conduction. Then ask the patient to do a 10-second exercise and repeat the CMAP.
What is the exercise given usually? Walking.
Ask the, no, not like that. Suppose you're doing the thumb, you can see the thumb. Ask the patient to keep on contracting the thumb for 10 seconds and then repeat the contraction. If it is ulnar, ask the patient to keep on contracting for 10 seconds and then repeat the contraction. Usually we do the distal muscles, so that way you can exercise. Not the repeated isometric exercise. You keep on contracting and then do the CMAP after 10 seconds.
Sir, one clarification, sir. In the laryngologist's note, the vocal cord movements were reported to be normal. Only atrophy was there.
And that is that is his report.
Yes.
Correct. Yeah, correct. But she could not make a voice anyway.
Yes, sir, but in organic dysphonia, there should be some defect in the movement of the vocal cords as well. So, sir, that's all.
But what is it? That's a good point. It is a good point. I also thought so. But her problem is she has also got weakness of the other muscles, like
Yes, sir,
pyrotros.
that's true. Yes, sir.
So that only that because we are not seeing the laryngeal movement. What is the laryngologist reported? I just gave you the report.
Sir, sorry, gag reflex, sir.
Gag reflex was also absent.
Okay, sir.
So I went ahead with an EMG in this patient. I did EMG in many muscle cells, so most of them. From the right corticeps vastus. There was no spontaneous activity. There is mild increase in the firing frequency. That's due to denervation. And mild increase in the interference. So right corticeps normal except for mild increase in the firing frequency and mild decrease in the interference pattern. Now let us see the rectus femoris on the initially vastus in rectus femoris. So that is affected muscle, so I thought I will do that. Again, no spontaneous activity. Almost normal. It's a polyphasis. But the interference has decreased. No spontaneous activity, normal MEP, mild decrease in the interference. That is from the rectus. Then when I to the left, TA, tibialis anterior. Again, no spontaneous activity. Almost normal EMG pattern. That is TA. Normal. Then right gastroc I did. but I could not complete it because she was complaining of severe pain, so I could not do it properly. Anyway, there was no spontaneous activity. Again normal. Again normal. Then E with the right deltoid. Now look at what's happened here in the deltoid now. There's got fasciculations. There are fasciculation potentials. The right deltoid. Voluntary activity. There is not much of a large amplitude there. And interference also decreased. Then from the right deltoid, sorry, that's right deltoid. Then from the right FDI, occasional fasciculation. Some other potentials are large and polyphasic, but again, not a real large potential. Decrease interference. Now, occasional fasciculation. Motor mainly a small amplitude. Some potentials are large and polyphasic. Almost complete interference. Then from the left biceps, see what is happening in the left biceps. Profuse fasciculations. This is spontaneous activity. Fasciculations and potential fasciculations. That is voluntary activity. Profuse fasciculation, normal size MAPs, but many polyphasics, almost complete interference. Then it from the tongue. No spontaneous activity could be made out. That is normal activity from the tongue. Then it from the paraspinal. Again, fasciculations and fibrillation potential. Some other potentials are large and polyphasic. So, positive waves, normal size MEPs, almost complete interference. So, this is from the EMG of the patients. There does not indicate a chronic denervation. The duration is only 3-4 months. Shows acute denervation is there in this patient, undoubtedly in the upper limb muscles. Now, what do you like to do?
CSF.
CSF, I did not do the CSF. Because
Sir, this is looking like a polyradiculopathy, sir.
only the, pardon?
Paraneoplastic workup.
I did not get the
Paraneoplastic
paraneoplastic workup. Okay, that I'm coming. Okay. So what I did was I wanted to get EMG from the laryngeal. That is the primary involvement, which are the ones maximally affected. I had never done EMG from the laryngeal muscle, so I called Dr. Jaikumar. to help me do the laryngeal EMG. So this is, I will not go to the, I will not spend time how it is marking and doing it. The moment you insert your activity, there is nothing called as baseline in laryngeal EMG. This is from the adductors. Then another one from the abductors. That's from the abductor. Again, there is continuous activity. So I didn't, I not done EMG, I cannot comment on that. So what I observed was that muscles were never silent. The moment you put it, continuous activity is coming. So there was continuous, even at rest. But the laryngeal said that was the normal in laryngeal muscles. He said he is doing it regularly. He said that is a normal phenomena. So he could not comment on that. So what did you want now?
Sir, according to the recent Gold Coast criteria for MND, one site for UMN and one site of LMN can be considered as anterior Hansel disease, can be taken as anterior Hansel disease.
But
Considering,
here we are no evidence of any human at all in this patient.
yeah, sir, that you told the knee jerk was brisk, sir.
Yeah, but that
Appropriate
no, that's correct. But brisk knee jerk alone can be normal also, no, in individuals, especially with the pain and all. So that alone does not suffice to call a pyramidal lesion. I should go as spasticity or upgoing plantar.
plantar
Plantar is indefinite, not upgoing or
indefinite, which can be taken as UMN, sir.
no. We have no clear evidence. No, there's no clear evidence of human.
Okay, sir. Then still muscle can be considered, sir, since IBM case.
Right, yeah. Still, we cannot rule out anticonception. That part I fully agree with you. But
Yes, sir.
to call MND, that's a little difficult. You can call something like a progressive muscular atrophy type of can call. That way is possible.
Yes, sir.
But that's not fit with the criteria. We are not demonstrating. Human part is not there.
Okay, sir. And then one more possibility is a muscle, sir.
Muscle.
Yes, sir.
Perfect.
Since IBM inclusion body myositis can have this fascicles, can mimic an MND, sir.
Right, perfect. That's perfect. English body myositis can mimic fasciculation. Not only that, inflammatory myopathy can also produce these things. So, what investigation you want now?
Muscle MRI, sir.
Before muscle MRI, CPK, no? I did a muscle MRI, I'll show that. The CPK was 2933, very high. Okay. Since the blood was taken after the EMG, I restarted the CPK after 4 days. Again in 2212. So CPK is undoubtedly elevated now. This is the first CPK, the second CPK. Now the next question now is in complicated myopathy, like inflammatory myopathy, like a paraneoplastic symptom, consider the age of the patient, lately rapidly over 3 months, or a metabolic myopathy like hypocalcemia. These are the things you have to keep in mind. So what do you want now?
Autoimmune myositis panel.
Panel, sir.
Myositis panel. Then, okay. Then I said serum calcium, common things first. Serum calcium, phosphorus, and TSH was sent because hypocalcemia I wanted to rule out. And myositis antibody profile and muscle MRI. These are the 3 things I planned. So and FDG PET also. FDG PET. See, why I prefer FDG PET over paraneoplastic antibodies. Many times they come as negative. Even if the patients could malignancy, they come as negative. So hardly ever I find it. I have picked up 2-3 antibodies, the paraneoplastic profile. Most of the time it comes negative. But when a FDG PET, you can become the malignancy. So I do, if PET is negative, then sometimes I go antibody profile suspicion is very strong. Okay, so I'll show you one by one. So this is a serum calcium done 9.7 normal, thyroid normal, phosphorus normal. Vitamin B12 was normal, homocysteine was normal. This is a myositis antibody profile. All was negative. This MDA, NHP, TF, TP gamma, all were normal. Then what else you want? So I did a muscle MRI. Why muscle MRI? Because there is some clues can get from a muscle MRI, such as dermatomyositis or other things. You can have inflammation of the fascia. With the facial inflammation, that's very typical of dermatomyositis. So I asked for any, and also any particular pattern of muscle involvement. As you said, in case of illusion body myositis, there is a characteristic involvement of the thigh muscles and the plexus upper limb. And the thigh muscle also, only portions, distal part will be affected, proximal part will not be, in that cordyceps itself. And that's it will be very characteristic of illusion body myositis. So that is the idea of doing the muscle MRI. So you were asking something.
Perifascicular atrophy, sir.
Perivascular atrophy. Then peripheral, apart from that, I'm not talking about MRI or muscle atrophy. The enhancement surrounding that fascia will be characteristic.
Okay, sir.
Perivascular atrophy, of course, is there.
Yes, sir. Okay, sir.
But that is usually not picked up in MRI. That is usually picked up in muscle biopsy. MRI, you cannot pick up that. Perivascular atrophy will be difficult. Okay, this is the MRI of the shoulder. I will show the static picture. You are not conversed with that. That is the suprascapularis, supraspinatus, subscapularis. I will show the static picture rather than going to the static film. So that is the supraspinatus, that is infraspinatus, and that is subscapularis. All were showing hyperintensity in the muscle. Then MRI, the larynx was done. And it will be difficult for you to maybe show the static film. There is hyper. So you can see the hyperintensity of the vocal cord. It's more on the right side compared to the left side. Both the vocal cord, right more than the left. And oval-shaped glottic space. Then MRI of the neck muscles was relatively normal, no hyperintensity of the neck muscles. Then did a MRI of the hip and thigh muscles. That is a gluteus maximus on the posteriorly. That is iliacus. I will show the static film. So this is the gluteus maximus, which is hyperintense. But it's shown there. In front of that ilia is the iliacus, muscle hyperintensity there. Then you can find the hyperintensity in the psoas major adjoining the spine, the vertebral body. Then in the little more lower down, you can see the piriformis. Posteriorly is the gluteus maximus, then piriformis. MRI, the thigh showed hamstring's hyperintensity. So you can find muscle, it's not a specific pattern at all. Muscle hyperintensity without a specific pattern such as inclusion body myositis or muscular dystrophy. So unlikely to be a dystrophy of any kind. More like something like an inflammatory or other myopathies. So what else you need?
Biopsy, sir.
Muscle biopsy. FDG PET, if some picks of malignancy, then we can avoid muscle biopsy.
FDG PET.
FDG PET was done toward paranephrosis syndrome. Normal. No definite PET evidence of any metabolically active lesion to sustain definite primary site or a paraneoplastic etiology in this study. Faint mild diffuse metabolic activity in the visualized muscles of the axial and appendiculoskeletal, likely inflammatory myopathy in the context of non-myopathy and elevated CPK. Indirect evidence, no direct evidence of anything in the FDG PET. Know what to do. All the investigations I have planned came as non-specific and negative.
Muscle biopsy with immunohistochemistry, sir. IHC, sir.
Okay. So at that point, I thought I'll start with the patient. Patients been there for weeks now in my ward without getting any treatment. Then I'm just, they also get irritated. Luckily for me, that patient is very nice people. Had faith in me. That's the most important thing to go ahead. The MRI, which has taken whole body MRI, muscle MRI, will be hell of a lot cost. But I did it for cheaper. So the patient also should be what do you call, have a faith in you to go ahead with that. So actually, this patient was very, very having good faith in me. So I thought I will treat with inflammatory myopathy, but I left out one investigation at that point of time. That is the parathormone. That came as very high, 95, upper limit is 65. So what do you do now?
So phosphorus level was normal, no?
Phosphorus was normal, calcium was normal. So I just consulted endocrinologist because I do not know, as you said correctly, I do not know what is causing the elevated parathormone. So he opined that is a secondary hyperparathyroidism. Asked for vitamin D, which was markedly low. This is the vitamin D level, only 6. Then the question came, should we what to do? So according to his advice, I put him on vitamin D and Shelcal. And patient is reviewed after 3 weeks. And after 3 weeks, he improved partially, but speech did not improve. The muscle power slightly improved. He is able to walk a little bit. That is already, I'll skip that thing. Neck muscle was still weak. Difference was also weak, but it's slightly better than before. He could walk better than before. The way he very difficult in walking before, now it is slightly better. So, to me, there was not much of change in clinical except for walking. Her husband said that her speech became slightly nearly normal after initially 1 week, but again became worse. That is husband's version. So what he did after repeated the vitamin D and PTH, after giving the course of vitamin D, the parathormone became normal, calcium became already normal, vitamin D also became normal. But even after correcting this thing, the patient did not have much of an improvement. Both have become normal. And see what has happened. Even after correcting the vitamin D, the CPK has gone double. It is CK value is doubled. Initially it was 2000. Then it has gone to 4700. So obviously it's not nothing to do with the vitamin D. So what to do now?
Right, sir.
In a muscle biopsy, any role, sir?
Yeah, muscle biopsy. Okay. So muscle biopsy was sent. Okay. So muscle biopsy is sent, but take a long time for the improvement, the report to come now. So in the meantime, I put the patient on IVMB 1 gram for 3 days, followed by oral steroid. Because it has been in the body for a long period of time. So I thought, anyway, there's nothing left behind. See, metabolic parameters were corrected. MND was ruled out, paraneoplastic ruled out. Now you have to treat. But some kind of inflammatory myopathy, so treated as inflammatory myopathy. And the biopsy result came as this is a biopsy report. That is ultimate conclusion. Inflammatory myopathy suggestive of immune-mediated necrotizing myopathy. On the both, I forgot the last part, maybe some lateralis. Okay. I do not interpret all these things, CD3, CD8 few positives, I do not know. This is the impression. So what do you want to do?
Sir,
HMG
IVIG.
detected.
Pardon?
HMG CR.
Okay. So then went ahead and asked the history. The patient's previous prescription was digged out and found out that patient had been ecosprin EV. Ecosprin EV means, it contained ecosprin along with atorvastatin. So I asked him to stop atorvastatin and patient was continued on steroid. And this is the prescription. And with that thing, the CPK came down to initial 4,957. with in steroid and IV ambient steroid. Then patient is followed after 1 month. The power is improved, delta is improved, but not fully well. Still lowerly muscle continue to become weak. But the husband was happy that she's now started preparing food for him in the kitchen. But she could get up much more easily now than before. Get down easily. But there is no improvement in the sleep. Weakness of posture muscles, both upper limb improved. No improvement in phonics. Now what will you do?
IVIG and other immunosuppressants.
Okay, that can give. So as Dr. Bitsu was telling, this is the thing you sent for. Because even after stopping this thing, it is CP gets improved, but weakness is improved. So serum was sent for anti-SRP and HMG-CR antibody. And HMG-CR antibody is grossly positive, markedly positive. Okay, so it was actually an immune-mediated necrotizing myopathy. So patient was given IVIG followed by mycophenolate and followed up after 3 weeks. This weakness is improved, neck has become initially weak, totally normal, or the upper limb has become improved, but phonation did not improve. They're all improved. I'll skip the 10% down. And see how she's walking now. Initially needed 2% to walk, now she's walking without any problem. But speech still aphonic. That is the only thing she has not improved. Neck muscle power is totally improved. Muscle power in the upper limb was also markedly improved, but she could not sit. But except for that, she could not sit from a low stool without support. Other things have improved. However, aphonia was still persisting. So autoimmune necrotizing myopathy, HMCR antibody-related autoimmune necrotizing myopathy precipitate better result. So that's the story of the patient. Patient presented as aphonia, and it was due to your culprit to us atorvastatin.
Where was this antibody done?
And where was it done, you know?
Antibody was done.
You know, frankly speaking, the diagnosis made by the pathologist. Because I sent the muscle biopsy to pathologist, I forgot her name. She was a pathologist, Sriyatra. She called me and said, this is showing more of rather than inflammation necrotizing. Was the atorvastatin there? Then atorvastatin stopped. Then she only said, why don't you send for HMG-CR? That's the thing you have to rule out. That's why I sent.
No, which lab? Which lab?
I tell you, till now I was not, because previously I wanted to send SRP and HSB. SRP is done, but HMCR is done in nowhere. Nowhere in the state was done. But recently, this pathologist only told me that they have started doing it in Sriyatra. The sample was sent to Sriyatra. I don't know it is done in the Amrita also. I don't think it is being done.
Sir,
Enhance.
sir, there is a
Immense, of course, immense it may be done. That's a different thing.
sir, there is a commercial lab, our lab in Mumbai,
Yeah.
which does in the myositis specific panel. They include two more, HMG and one for that
SRP.
yeah.
SRP.
No, SRP is there in all
Yeah,
panels,
right.
but this includes two more. One is for HMG and one for this. I forget the name. So it does two more. So that our lab in Mumbai does it.
Okay, that's very bad. Because when I had sent before, specifically mentioned they did not do it. They said it is not done. This pathologist only told that it is being done in Chitra.
Sir, why F1 is not improving, sir, even after IVIG?
No, I was waiting. No, I started her on IVIG. After that, I started put her on. No, I continued in steroid, waiting for the improvement to come. Because all the muscles has improved. I hope that I think that she'll also improve in time.
Okay.
HMGCR always occurs in the context of statin use, or can it happen without statin use also?
It can occur without statin use also, but statin is the one which precipitates it. Precipitates the myopathy.
Sir, it's so commonplace to use Atorva for age stroke patient.
Yeah, every patient is on atorvastatin. I don't know which patient will develop. It's very difficult to predict. In fact, the story is that when the patient initially came with elevated CPK, asked to stop atorvastatin. Then what happened? He stopped. The husband stopped atorvastatin. The patient had been under follow-up by a cardiologist. Cardiologist fired the husband. Who asked you to stop the atorvastatin and all? Then he restarted acquisition. That is when the whole become worse.
Sir, in initial examination also, sir, while you are checking right deltoid, she is wincing her face, sir. Like some pain is there, like that she is wincing her face. In first slides, in examination, sir. Now you show.
Right.
Was there any asymmetry in the weakness from on the right and left side?
No, not much of asymmetry at all. Not much of asymmetry. Almost same power. But in the body limb band, she did not complain of, as you said, she was wincing. There may be some pain. She's totally aphonic. That is why you have to indirect evidence that she is having pain.
So EMG wise, it was myopathic like earlier.
No, EMG was not at all like myopathic. EMG was like a neurogenic pattern. Now I'll come to this thing. Now, this answers your question. I searched literature and find out. I have known the inflammatory you can produce. Can fasciculations be present in necrotizing myopathy? Despite being atypical, there are specific situations where fasciculations have been noted alongside necrotizing myopathy. There is active myopathic process. In some cases, inflammatory myopathies, including necrotizing types, the disease process can produce spontaneous electrical activity, which may appear as fasciculations on EMG. This is particularly true during the phase of active inflammation fiber destruction. Then, when fasciculations may occur on its active disease process, then inclusion body mass is another condition. So most of it has neurogenic features. Because it's a chronic insidious condition, you can note both muscle, myopathic and neuropathic features on AVMG. Then a few words about HMGCR-related necrotizing myopathy. Is an autoimmune disease where the body attacks the muscle tissue, often triggered by statin use, leading to a severe muscle weakness and high creatine kinase. The condition is caused by antibodies against HMGCR and requires immunosuppressant therapy to manage, and stopping statins alone is not often sufficient. Detection of anti-HMCR antibodies in the blood is highly specific for the disease. Presence of these antibodies is sufficient for the diagnosis in right clinical context. Treatment typically involves combination of immunosuppressant corticosteroid, negative IV immunoglobulin. Is The CPK is elevated to 1,000 to 20,000. Other symptoms, myalgia, some people tell us dysphagia. But nobody ever mentioned as no inflammatory myopathy, and epidemic is mentioned. Aphonia is one of the causes. The usual inflammatory myopathy is dysphagia only. Tangential muscle affection is very rare. And in this case, is worth publishing.
Yes, sir, definitely.
Yeah.
Sir, this lab that I'm mentioning,
Yeah.
most of the labs do 16 antibodies. The lab in Mumbai, our lab is doing 18 antibodies, which includes HMG-CR and CN1A for inclusion body myositis.
Okay. I'm hearing for the first time CN1A for inclusion body myositis.
Yeah.
CN1A.
CN1A.
CL1.
Cytos 1A.
Okay. Right.
So these two are included in that 18 antibody panel. Usually everybody is doing 16 antibody panel.
Okay. Which can you just send in per WhatsApp with that lab's address and the antibodies?
I'll send you the WhatsApp you the number of the person who is associated with the lab.
Okay, thank you.
What is the price of the panel?
The panel price is 18,000 and they charge 800 for the courier charges. 18,000.
Okay. Thank you.
The lab? Our lab, OUR, our lab.
In Mumbai.
And they actually claim that they give reports for the other tests within 1 day. 24 hours is the turnover time for a working day for all the other antibodies for like autoimmune encephalitis panel and all. So they say that you get a quick turnover. Maybe they might be charging a little more, but sometimes when the patient is serious and you want an answer immediately, the 24 hours is. I'll type the number in if I have. Yeah, 1 second. And let me check.
Sir, but the sample needs to reach the lab within 12 hours, so the serum may get lice, sir.
They'll collect it. They'll manage the collection and all.
Okay, sir.
Let me write in the chat box. I'll just have to see. I'll write in the chat box here. The name of the person is Viral Vadwai.
Number also.
Yeah, I'll write that also.
Lab is at Mumbai, yeah?
It is in Mumbai.
So address is available in the Google.
You can text this person. Our lab. I'll just write the number now. 98203 88855. I am Dr. Butch. You can give my reference if you talk to him.
Okay. Shall I go to the next case or stop here only? What do you think?
Yes, sir. Next.
Okay. This is a story of a 62-year-old man. His complaint started 45 days back as numbness of the right sole, which ascended up to the knee within 1 week. He also noticed walking difficulty for the last 2 weeks in the form of requiring extra effort for walking. Heaviness of both the legs more on the right side. History of hesitancy in menstruation for the last 2 weeks. For the last 3 days, he noticed loosening of the chapels on the right foot. So, total reached 45 days back and numbness of the right sole. Then developed walking difficulty, heaviness of both legs, then bladder problems. 3 days he noted weakness, heaviness, and bladder problem and numbness. Okay. So this is the video of the patient. Upper limb tone power all normal. Small muscles were normal. His neck abdominal muscles appears weak. He could not lift up his this thing. Beaver's man was negative. Tone was slightly maybe increased on the left side. I'm not very sure. Hip flexion was weak bilaterally. More weak on the left side. Knee extension was weak, more on the left side. Abduction was normal. Adduction was normal. Hip extension was normal. Hip flexion was also, knee flexion was also normal. Dorsiflexion on bed, actually ACL was weak on examination the bedside. Dorsiflexion was also weak when he asked to stand on heel and toes. I'll show later on. Okay. Then coming to the reflexes, upper reflexes are normal. Finger pressure I could not elicit. Abdominal reflex was elicitable. The knee jerks, right knee jerk is well elicitable, left is decreased. Then both ankle jerks were absent. Plantar was mute, indefinite. Test sensation was normal. His mind diminished below the knee. But if you look at the pain sensation, there is a level in the mid thigh. There he is able to feel. On the right side, it went up to the abdomen. There he is feeling the abdominal pain. There is a level for the pain. Vibration is present all throughout. JP is in the upper limb normal. Lower limb is absent on the right side. He said left side it was present. He said correctly. Axillary was negative. This is the way he walked. See, the knee goes into flexion while walking, indicating more plantar flexion weakness. He could not walk on toes and heel. More problem for walk on toes. The toe walking not at all possible. Knee goes into flexion. See, he cannot go and walk on toes. He could not initiate walk. Trendelenburg was negative. Thrombus was mildly positive. So on examination, cranial nerves all normal, motor, upper limbs tone normal, power normal, lower limb tone normal, power, weakness of both hip flexes, dorsiflexes and plantar flexes on standing and walking, and both EHL. Other muscles appeared normal. Patient could not stand on heel or toes. Trendelenburg test was negative. DTR upper limb just elicitable normally. Fingerprints was absent. Lower limb knee jerk both are elicitable. Right knee brisker compared to the left. Ankle jerks were absent. Abdominal reflex present. Plantar mute bilaterally. Sensation touch impaired over the leg on the right leg. That is making mistakes sometimes. Pain and temperature decreased below D11 on the right side. D below L2 on the left side. Vibration normal in the upper and lower limb. JPS upper limbs normal, lower limb normal in the left foot, consistently impaired in the right. So he has got posterior column, JPS sensation impaired in the right foot, pain decreased in both lower limb. The level was high on the right side at D11. Vibration is normal. So this is the area of pain loss, right side and left side. This is the area of JPS on the right foot only. Okay. Gait walks with dragging of both feet. That dragging because of the heel, dragging because of the plantar fascia weakness. So where is your localization?
Hip abduction was normal, sir.
Hip abduction bedside was normal. Adduction was also normal. Hip flexion was weak.
Myeloneuropathy, sir.
Okay, myeloneuropathy. Okay.
Saddle area, sir. Saddle.
Pardon?
The saddle area.
Period area, I did not examine the sensation. Because feet were all normal, touches normal, except the right lower limb. So I did not, he did not complain of period anesthesia, only hesitancy was there.
It is like a partial brown segment like presentation with
Yeah.
JPS loss on one side. But the site of JPS loss is not showing exaggerated jerks also. So lesion affecting the posterior cord with involvement of the corticospinal tract with some component of element neuropathy or radiculopathy associated with it.
To call brown sugar, there's a problem. Here we don't have tract involvement. I agree with you, spinothalamic involvement. It is present on both sides, more on one side. However, there is no evidence of pyramidal weakness in this patient. Whatever the weakness we obtained was that of an element weakness, because hip flexion was weak with the decreased knee jerk and dorsiflexion plantar weak with angle was absent. There may be underneath myelopathy cannot be ruled out, but what is definitely is got an element finding. That's a tricky case.
And Swiss.
Pardon? Okay, let us now analyze the problem. One, the paraplegia weakness is element, clearly because plantar flexion is undoubtedly more weak. So that's not the pyramidal pattern at all. Dorsiflexion is little more powerful than plantar flexion. So, and the reflexes were diminished. And clearly there is a weakness is element. So it could be due to, say, extensive radiculopathy is a possibility, or at least inside the lower part of the spinal cord. See, radiculopathy is equal to the corresponding segmental affection in the epiconus and conus. Not forget about conus, epiconus. So it's lesion there, or the radical behaves the same. Only thing is one is inside spinal cord, the other is outside in the root. If it's only pure radiculopathy, you can't explain the sensory loss, sensory level up to this thing, unless the roots surrounding the thoracic are also getting involved. Now, the second point to analyze is a sensory level on the tongue-ear level. So, one possibility, as you already thought, might be an associated myelopathy, or the radiculopathy extending upward to the involved in the root on the side of the cord. That's a little odd, because only pain is lost up to that level. Other sensations are not lost. So possibility of an extensive radiculopathy going up to the side, the meningeal disease seems less likely. More likely there is a cord lesion plus an element paraplegia. So logically, we can think the lesion is inside the cord in the epiconus region, which is going up to the thoracic cord to explain the sensory level. That's the thing which only we can postulate. And that's the last one. That's more possible in taking everything into account if you want to localize to a single lesion. For example, this is what I postulate. Say, lesion must have been in the central part of the cord, say, extending from mid-dorsal level up to the L1. Okay, LETM-like thing, producing element paraplegia, mainly the L5S1, coming down up to the S1, producing the weakness of the lower limb and decreased knee jerk on the left side and weakness hip flexors. And the lesion might have been extended up to the lateral funiculus to affect the lateral spinal tract, producing loss of pain temperature. Suppose this has gone outward towards the spinal thalamic tract, it could affect both the tracts up to that level. Okay, that can explain everything. And the loss of JPS on the right toe might have been either due to the affection of the posterior column on the right side or the root entry zone of the S1 segmental level, because we are primarily thinking of an element lesion extending from, say, upper dorsal or not upper dorsal, lower dorsal to the entire epicornus region up to the S1. That can explain the element paraplegia. By the tract, it has gone outward to encroach upon the spinothalamic tract. That can explain the pain and temperature loss, pain loss on both sides up to D11. Why then joints is difficult to explain unless that lesion is encroached posteriorly to the posterior column, or that particular at the S1 level it has encroached onto the root entry zone. That is only to explain everything together. What do you think? This is my postulate.
Sir, but
Where
hip abduction was normal, sir. That is, the S1 radical pattern was not there, sir. Gluteus medius minimus was normal.
I agree with you. But even the lower limb power, the dorsal plantar flexion power, dorsal flexion is relatively okay, but it's mildly weak. Plantar flexion is more affected. So that's clearly element only. See that why there is a different involvement. If it is a significant weakness of the plantar dorsal flexion, definitely it would affect the hip abduction. This is only mild weakness. Somebody hip abduction can be spared. So, for example, if you take an L5 radiculopathy, the only weakness may be in the EHL, but all of the muscles supplied by the root may be normal because of the severity. As the disease progresses, it becomes more and more, L5 root is affected more significantly, other dorsal flexion muscle and revert to become weak. So, it depends on the severity of involvement. Your point is well taken. But the thing is, that's only 4 to 4 plus power on the distal part. At the bedside, I could not overcome this muscle sector. Suppose if I asked the patient to get on the squatting position, probably I could have picked up the weakness of the glute. Have I made the point clear?
Yes, sir.
Yes, sir. But one doubt, sir.
Yeah.
His knee jerk was brisk, sir. Ankle jerk
Knee
was
jerk-
lost.
Angle you has lost between the right knee and left knee. You can either call left knee is decreased or right knee is brisk, whichever either is possible. We do not know his previous reflex status. So either right knee check normal, left decreased, or left normal, right brisk. That we cannot say. Either way, we can explain. Even if it is brisk, you can explain by the postulate of the cord involvement in the intrinsic myelopathy has gone out anyway to the lateral funiculus to involve the spinothalamic tract. Just
Yes, sir.
anterior to
But
the pyramidal.
this problem, as Dr. Samya sir has told, the Brown-Sequard type of presentation usually presents with the ipsilateral posterior column and motor tract and contralateral pain and temperature. But here,
Correct.
the patient has the ipsilateral pain and temperature. JPS is also lost on the same side, and there is weakness. I mean, the weakness is also worse on the right asymmetric, sir. Right and left asymmetry, sir.
Yeah, here what is happening, the spinothalamic tract is not affected on one side, bilaterally. Okay, that means the lesion has gone on to both the lateral funiculus, but it may be asymmetrical. Why the posterior column should not ideally be involved? Okay, unless it may include the posterior column, or the same lesion which is shown here has gone on to the root entry zone. Even in the intramedullary lesion, can produce posterior column, 1 or 2 segment. If that at that level, the lesion need not be tracked. It goes posteriorly at the root entry zone where the posterior column fibers are also cut off. If we can draw here this area, these are not the diagram. That is why that is shown in the lowermost here. If the lesion at the S1 level go to the root entry zone again, you can have loss of joint presence on the right foot.
Okay, sir. Okay, sir.
And sir, if the thoracic cord is involved, the abdominal reflex would have been absent. This was clearly present.
Yeah, the involvement was, it was up to the D11. The spine was lost only up to the D11, not above that. On the left side is only up to L2. So abdominal reflex may be preserved. Okay, what investigation you need?
MRI.
MRI. So this is MRI. I'll show the MRI. This is the lumbar spine. Can you see something there? Okay, I'll get to the main. This is cervical. I think cervical I skip in the interest of time. The main finding was the dorsal spine. So what do you see there?
L18.
Extensive T2
L. Okay, right.
Exactly.
Now I'll show the dorsal axial spine also. Look at the MRI very carefully. Okay. Long SNC appendicity within the cord, you can see. Up to the epiconus conus region is coming. Epiconus and conus get less affected, mainly in the lower dorsal epiconus region. Okay, this is another lower dorsal and lumbar. Lumbar cord, nothing very important. So what is the diagnosis now?
Lithium.
Elite. Do you think I will show any lithium case to you in this forum?
Pull out the guard.
Okay.
Syringe possibility, sir.
It's not a syringe one. It is a called lithium. Even I did not show. Yeah. Now I'll show some more films. Okay.
Contrast, sir. Contrast, sir.
Contrast also done. Contrast it was not it should not see any significant finding. But see, this I'll show that some more film. Then you can try to find out anything odd.
The vertebral body.
No. Cleanly
Cox-Alajuanin syndrome, sir. Dural avium.
Dural avium.
Okay.
Cox-Alajuanin.
Dural avium, sir.
That's correct. Dural avium, dural avium fistula. Okay.
Yes, sir.
One more thing, if you can make it, that's good. I'll show that picture once again. This you can see the vessels there. Tortular vessels going down. Okay. Now this is still sick. They can forget it can make it the vessel only. They can find the vessel on the dorsal aspect. Now, this picture, concentrate. Can you make out anything in this patient?
This vertebral body and the hemosiderin.
You can see. Ah, good. There is a hemosiderin deposit around the cord. See the dark thing around the cord. See this one? Beautiful. That means the patient had bleed earlier. Yeah. So it's a dural AVF fistula with bleed. So this is the dural AVF which you can make out there. See that small dark thing is the vessels which is on the dorsal aspect. Here also you can make out the anterior part of the cord that is dark here. This is another adjusted the window width. You can find out the dural AVF. And this is again the axial cut showing the vessels. And this is hemosiderin pigment. See the dark ring surrounding the cord. This also you can make asymmetrical dark ring. Okay, that's the answer. Okay, any questions? No, only point is that when you get an LETM, never forget to ask for T2 space sequence. You should take a contrast, of course, to find out a meningeal pathology and infective cause of LETM. That is a must. Contrast is a must. Secondly, T2 space. T2 space is something equivalent to our C sequence in the brain, where the CSF abnormality, something in the CSF can be easily made out. If you don't take it, then you will miss the spinal dural AF fistula.
So any spinal bruit for this patient? Spinal bruit?
No. In fact, I did not look for it. But usually they don't produce any bruit at all. This is inside the dura.
Sir, T2? Can you spell
T2
it, sir?
space. SPACE.
Oh, just like that swan in brain.
Just like a
Swan
span. Yeah, right. Space sequence in the cord.
That is only T2 thin cuts.
Like thin cut, and they adjust something there in that space sequence you had written. Thin cut, of course, it is thin cut only.
Heavy T2.
Yeah, it's a heavy T2, correct. It's heavy T2. Heavy T2 weighted sequence. Okay, then shall we stop? Any questions?
Yeah.
We'll stop.
Thank you, sir.
Okay,
Thank you.
sir.
Yeah,
Thank
good
you,
night.
sir. Good night.
Yes.
Sir,
Thank you,
good
sir.
night.
Good night.
Good night.
Sir, thank you, sir. Thank you, sir.
Thank you. Good night. Thank you. Thank you.
Good night, sir. Good night, sir. Thank you, sir.
Good night. Good night. Good night. Thank you.
Thanks, sir.
Thank you, Bindu. Thank you. Good night, Bindu.